Good afternoon. We got 6 or 7 people online. I'm Professor Dillon. I think many of you have met me, so welcome. Who's got the children in the background there? They need to get rid of the children into another room. Can't have children in the same room. It disturbs everybody, please. So you need to be in a room by yourself without any disturbances. Thank you. So I've got the list. So welcome to people from UK. I think there are 3 or 4 from UK. Tanusha, Daniel, and Saida. Is that right?
Yeah.
Yeah, and then we've got 4 or 5 of our international students from family medicine students who will benefit from what I'm going to talk to the ENT students about as well. So I think there's Asma, Rachel, Zainab, Khadija, Sakiba, and Deepa. Is that right?
Yes. Yeah.
Okay, what I'm going to do today is try and go through 2 or 3 topics. One is snoring and obstructive sleep apnea, which is an increasingly major issue in the developed world, and certainly in the Middle East and India, a very big issue that is developing and will continue to cause great problems in the future. And then I'm going to talk a little bit about sore throats and the larynx and voice problems towards the end. So we got a couple of hours. We may not use the whole of the 2 hours, but let's see how we get on. So is that okay with everybody else?
Yes, sir. Yeah. Yes, sir.
Okay. So the first is snoring and obstructive sleep apnea. If we go to this first slide, you see this sagittal section of the head and neck. You all recognize that?
Yes.
Yeah, okay. Well, the airway and snoring really comes from the upper airway. The lower airway is the lungs. The upper airway is really larynx and above. So the larynx is down here, where the pointer is, and the upper airway here. I was pointing to the esophagus. I hope you noticed. The larynx is here, and anything above that is the upper airway. And the upper airway consists of this area, and you can breathe through your mouth, as you know, particularly when you're swimming, okay, or you can breathe through your nose, okay, but it all ends up as a common pathway, whether it's the mouth or the nose, it would end up as a common pathway into the larynx and then into the trachea. So snoring is a sound made by upper airway obstruction. So it's very important to remember that lower airway obstruction produces a musical sound, which I'm sure everybody's heard. What's the musical sound that you hear in asthma? What is it known as? Daniel, what's that term?
Wheezing.
So wheezing, which is a musical sound, you're absolutely right, Daniel. Wheezing is a musical sound. It's invariably associated with the lower respiratory tract. Stridor is a snoring is a horrible, stertorous sound with no musicality. That's why it disturbs partners and disturbs people who are in the same room or even in the same building as the snorer. And what snoring means is somewhere along this nasolaryngeal tracheal or orotracheal laryngeal pathway, there's a narrowing in the airway. So the air moving through the airway, instead of being nice and laminar airflow, which has no sound, the narrowing produces a turbulent sound, okay? And the turbulence is what you hear. Now, clearly, if the narrowing is, say, the tongue falling back into the airway, that's going to vary from second to second, minute to minute. The way the palate moves back and the blocks the airway, that will change from minute to minute. Therefore, the sound of snoring is not constant. Therefore, people who are partners can't get used to it. So snoring means there is some air moving. I've mentioned to you that if the airway is nicely opened, you get laminar airflow. There's no sound. What do you think would happen, Deepa, if the airway was completely blocked? what sound would you get? Whose phone is that? Get that. So what sound would you get, Deepa? You know?
Something like sleep apnea will occur.
Pardon?
Something like sleep apnea will occur.
No. Saida in UK.
Stridal?
What sound would you get?
Like a stridal sound.
No. So if the airway is blocked, what sound do you get? What sound anybody get? Pardon?
Wouldn't get any sound.
Absolutely right. If there is no air moving, you're not going to get turbulent airflow, are you? So if the upper airway gets blocked, supposing you want to strangle your husband or your wife, okay, they'll be able to shout and scream while there's air moving in and out of their lungs. The moment you completely block their trachea or their airway, there is no sound. So no sound in relation to snoring and obstructive sleep apnea may be fantastic because it's laminar airflow, or it's absolutely awful because the airway is totally blocked. Now, if the airway gets blocked and there's no sound, what do you think, Tanusha, will happen to the oxygen saturation in the blood?
It will reduce.
It will reduce.
Yes.
How much do you think it can reduce by?
Well, it would probably reduce by 100% if it was completely blocked.
Well, you'll be dead. But most snorers don't die, do they? They wake up the following day pretty unrefreshed and with a very tired spouse.
1% then?
Well, no, I mean, would your body, would your brain allow your oxygen desaturation to get to 40%? Probably.
No.
Okay, so what happens is you deoxygenate during the time that the airway is blocked. The oxygen desaturates, and your brain kicks in saying, "You're dying, please wake up." And you know, and I know, and if you live with snorers, you may have experienced it, that they're snoring away, there appears of what seems to be like a struggle and no sort of particular sound, and suddenly there's a gasping as they come up for air. That's the brain saying, "You're dying, please wake up and take a breath, otherwise you're going to die." Okay? Now, the definition of obstructive sleep apnea, does anybody know the definition of obstructive sleep apnea? Sorry.
Is it 30 apneic episodes in 7 hours of sleep?
No, well, let's see what let's look at one episode. What about Zanab? Zanab, what do you think? What is the definition of an obstructive episode? Do you know? What about you, Khadija? No? Anybody? Okay, let me tell you. Let me put you out of your misery. It's at least 10 seconds of no air moving. Okay, and this can be detected by various bits of kit during sleep studies. So 10 seconds of no air moving or total obstruction. It could be 15 seconds, it could be 20 seconds, could be 40 seconds, could be 50 seconds, but anything that's 10 or above. And there are patients that might obstruct for 30, 40, 50, 60, 70 seconds. And I've seen patients where they desaturate down to 65%. Now, if you were under an anesthetic, you personally under an anesthetic, and your oxygen saturation went to 65%, your anaesthetist would be having heart attacks. Okay, so there are patients who desaturate significantly. So it's 10 seconds or more of no air moving. That's one obstructive episode. Okay, now if the air moves, normally the air flows at a particular rate in and out of the airway. If you reduce that flow by 50%, so the airflow is 50% of what it should be normally, that is known as a hypopnea. So if you've got the two definitions, There's apnea, 10 seconds or more. Hypopnea is where the airflow reduces by 50%. And if you add the number of episodes per hour of those, you get the total A, apneic, H, hypopneic, index, okay, which we will come to later. So does everybody understand that principle?
Yeah.
Okay. Now, if we take just the area where I work, which is called Southwark CCG, for those that are abroad, it doesn't matter, it's just a small little region in London, South London. It has a population of about 300,000 as a sort of local health economy. We know from various NICE guidelines, National Institute for Clinical Excellence, that 20% of the adult population snore and 1% have severe obstructive sleep apnea. Okay, so in Southwark, there are 3,000 patients with severe obstructive sleep apnea. I haven't even mentioned the moderately severe or the mild. So if you take India as a population of 1.2 billion, and even if it's 0.5% of patients having severe obstructive sleep apnea, that's a huge number of patients. And if you take a population of the UK of 65 million, 10% of 65 million is 6.5 million, and 1% of that, 1/10 of that, you've got 650,000 patients minimum in the UK with severe obstructive sleep apnea. And we'll come to the importance of that in just a moment, okay? The issue is that only 20% of these severe obstructive sleep apneics in the UK have been diagnosed and treated. And that's figures from the British Thoracic Society. So there's a huge amount of unmet need, and there's a huge economic and personal cost, which I will come to in a second. Okay, so in Southwark, we've got 2,500 patients with severe obstructive sleep apnea who are undiagnosed. Okay, and in the UK, probably over 500,000 patients with severe obstructive sleep apnea are undiagnosed. Okay, let's just go, sorry, I went to the next slide too quickly. So supposing you have obstructive sleep apnea, you have disrupted sleep because you have deoxygenation, you may even wake up with it. What sort of symptoms might you have of obstructive sleep apnea? Tanusha, what symptoms might there be?
Daytime somnolence.
Yeah, so how would that manifest itself?
So falling asleep during the day.
But when in particular? I mean, we all like falling asleep if we possibly can.
Well, in things like if it's in quiet places or in car journeys.
Okay, you're right. You're just skirting around the correct answer. The daytime drowsiness generally occurs when you're doing boring, repetitive activity. So if you're driving, which is boring and tedious, motorways particularly, or you're watching a boring program, or you're at a dinner party with boring people. You know, there are a lot of those around, okay? And you just nod off into the soup, okay? So there's daytime drowsiness. And what about you, Asma? Asma, what other symptoms might you have?
Lack of concentration.
Yep. In order to reboot your brain, you need decent sleep. And I'll come to the various stages of sleep you require. But if you have disrupted sleep, which is what apnea will give you, you can't reboot your brain, and you get a lack of concentration, and actually the sharpness of your memory goes. So people think they've got early Alzheimer's, you know, age 20, 30, 40, and 50. So, you know, the sharpness that you have in remembering things, that tends to go. Okay. Anything else? Well, people get very short-tempered. Okay, lack of sleep can change your personality. Okay, so you have people with very low threshold for arguing and losing their cool. So sometimes couples who are probably very much in love, the husband, that's usually males that snore, and we'll come to that in a moment, they become very short-tempered. And it may be not because they dislike their spouse, it may be because they have obstructive sleep apnea. So there's a whole series of ways they can present. Now, if you fall asleep at the wheel of a car or a lorry, remember long-distance lorry drivers? And if you're in India or the Middle East, where some of you students are, you have long, straight roads, don't you? And you must hear a lot about lorry drivers and articulated trucks going off the road. Yes. A proportion of those will undoubtedly be obstructive sleep apneics. Okay? So if you're not concentrating well, you're not working well, your relationships are falling to pieces with your spouse, what might happen to you mentally, Shakiba? What sort of a mental problem might you get into? Well, supposing your husband wasn't talking to you and you weren't working well and you can't concentrate, you know, you don't feel right, you don't have energy during the day, you might get depressed. There's a large number of people, relatively young, who are under the psychiatrist for depression. They have is obstructive sleep apnea. And when they sit in a psychiatrist's chair, the psychiatrist said, well, did you have a bad childhood? And they say, no. Were you molested? No. Was school terrible? No, it was all fantastic. Oh, there must be something wrong with you because you're depressed. They don't twig that this may well be not a sort of a usual etiology for depression. It may be something like obstructive sleep apnea. And I'd be very guarded when you take very young people. Clearly there'll be those that have disruptive family life and everything else, but there are others where it just doesn't fit. In which case, consider obstructive sleep apnea. So here we are. There are a number of symptoms. We've mentioned excessive tiredness, memory, concentration. If you can't concentrate, you can't perform at school. So very young children with obstructive sleep apnea, their school performance may well suffer. They're falling asleep all the time. They can't concentrate. Motor vehicle accidents I've mentioned, obviously work-related accidents. You may have problems with your spouse, depression, and overall life is horrible, okay? So obstructive sleep apnea can affect you considerably. Now, let's try and think what happens if you deoxygenate. What are the two most important organs in your body that really can't do without oxygen? Khadija? Brain, yep, that loves oxygen. Yep, brain. So if you're deoxygenating, your brain starts giving up. Okay, so remember, concentration goes. Okay, ability to remember. You know, your mental performance goes. Anything else? What's the second?
The
heart. The other very sensitive organ to deoxygenation is the heart. That packs up. Okay? Now, obviously, every single cell in the body requires oxygen. Think about that. Every single of your billions of cells in your body requires oxygen. Otherwise, it cannot perform its duties. So frankly, obstructive sleep apnea can affect almost any organ in the body, any tissue in the body, because every single cell in the body requires oxygen. So if we go to this next slide, we can talk about some of the elements and some of the symptoms. So we've talked about mood disturbance. Can you all see that? Mm-hmm. Mood disturbance, daytime sleepiness. We've mentioned loud snoring. Diabetes. Why do you think we might see an enhanced incidence of diabetes amongst obstructive sleep apneics? What about you, Zarnab? Why is that? If I strangle you, which is effectively what obstructive sleep apnea is, if I'm strangling you, you have the fright and flight mode instituted in your body, don't you? You want to run away. And to run very fast, what hormone do you need? Anybody?
Adrenaline.
Yeah, you need adrenaline. Okay. So, Daniel, if I pour adrenaline into your system, what is it going to mobilize? What do you need for your muscles to run very fast, besides oxygen?
Heart and lungs to pump on.
Yeah?
Faster.
What's the substrate you need to give you energy?
BP.
Glucose.
Glucose.
No, one at a time. You need what? Glucose. You need sugar. Okay? So, obstructive sleep apnea, when you have an episode and you get deoxygenation, you get adrenaline poured into the system, and that releases sugar into the system. And eventually, the patient becomes insulin intolerant. Okay? So if you're a pre-diabetic and you get obstructive sleep apnea, you're more likely to become diabetic. If you are diabetic, it's going to be more poorly controlled. So diabetes has a huge incidence with obstructive sleep apnea. What about obesity? They generally tend to be large. Not all of them, but a lot of them seem to be large. Saida, what do you think? Why might they get fat?
Men and women have different areas where they kind of store the fat. So women tend to store in the lower part of the body, whilst men will kind of deposit more fat around the neck area. So that could contribute to.
Yeah, but people who are that's general fatness, if you like. Okay. Why does obstructive sleep apnea make you more fat?
Because they are inactive.
Yeah,
inactive and sleepy always.
Yeah. The main issue is, if you haven't had a decent night's sleep, you want to get to bed as soon as possible. You wake up tired. Your physical activity is reduced dramatically, and therefore you're likely to put on weight. You may go into comfort eating. And remember, when the adrenaline is pumping around and it's getting rid of glucose, the moment you eat, the body thinks it's got to store more glucose and glycogen into the system for the events where it's needed. So it's hungry for any glucose that you have, any energy-giving food. It lays it down. So there are 2 or 3 ways why in obstructive sleep apnea you're likely to get fat. Let's just go on to cardiac arrhythmias. What about you? Who have we got here? Tanusha. Why do you think there's a higher incidence of cardiac arrhythmias in obstructive sleep apnea?
Maybe it's due to the decreased oxygenation to the heart.
And what did that do? What was the consequence of a decreased oxygenation and flight and fright? What did it produce?
What did it produce? Adrenaline.
Yeah, and adrenaline can affect the heart muscles very acutely to produce arrhythmias. Okay, remember, if you inject somebody with too much adrenaline, what happens to your heart? You get an arrhythmia, don't you? Even normal people.
Yeah.
Okay? So if you've got this stuff coursing around your cardiovascular system, the chance of something happening to your heart is going to be that much greater. And as a consequence, the heart, not only is it more potential for arrhythmias, but what happens to the heart rate, do you think, Daniel?
Increases.
Okay, so you get a racing heart, and supposing, you're a very fit man, I'm sure. So supposing your heart rate is normally 70 beats per minute. In the night you have bad apnea, and you're generally racing along for hours on end at 100 or 120. What will eventually happen to your heart muscle?
You will be fatigued.
Hold on, I'm talking to Daniel.
Would it hypertrophy?
It could hypertrophy, but what else could happen?
Just get tired and fatigued?
Yeah, it packs up. you get heart failure. The muscle cannot cope. This is a little bit like patients with hyperthyroidism. Their normal heart rate may be 120 beats a minute, whereas it should be 60 or 70. So their heart is working twice as hard as normal. And you know, eventually when you reach the age of 70 or 80, your heart packs up, doesn't it? But if it's been beating twice as fast for several years, if not some decades, it's just going to pack up quicker. So people with obstructive sleep apnea may also have congestive heart failure. And we know why the sudden death?
Are you more likely to trigger an arrhythmia?
Yeah, trigger an arrhythmia, which kills you, or you may get a stroke. Okay, stroke is very frequently associated with bad obstructive sleep apnea. Okay. Okay. Now, if your heart is beating at a hell of a rate, okay, and the adrenaline is actually constricting your blood vessels, you may actually suffer this condition. So, Zanib, what is this condition? Hypertension. Okay, if you have adrenaline running around in your blood for 6 or 7 hours during sleep, you're going to suffer eventually hypertension. If you already have hypertension, you're more likely to have uncontrollable hypertension. And polypharmacy in hypertension usually means there's something else going on. And don't keep changing the pills and adding pills, because that ain't helping. So, if you've got people with bad hypertension and it's not easily controlled, think obstructive sleep apnea. Okay? Now, what about this quite important thing down here? Who's going to talk about sexual dysfunction and obesity? Why might that happen? Loss of libido.
General tiredness and mood disturbance?
Yeah, you're generally tired, absolutely. And if you're, if you're a pain in the butt to your wife or your spouse, they're not likely to produce any great favours. But it is actually the physical tiredness which is usually the issue. Obviously, I've mentioned the incidence of diabetes is that much higher, and therefore you're more likely to have erectile dysfunction as males. Okay? And one very important symptom that's frequently missed is this one here, nocturia. So, Sakiba, why do you think they may have nocturia? So if they're 35 years old and they get up twice a night to go and have a wee, seems a bit odd. I'm 61 and I don't get up. So my prostate isn't that big. So it's at age 35, 40 with people with obstructive sleep apnea, it's not going to be prostate gland. But why do you think they might get up? Sakiba? Anybody? Yeah.
Blood sugar is not under control.
You've got to shout.
Blood sugar is not under control.
It's not really the blood sugar. Somebody else? Have a go.
Psychological?
No. Psychology doesn't give you nocturia, does it?
Is it because you're more awake, so you're more likely to sense that you need the toilet?
That is partly it, but it's based on what happens with the adrenaline. What does adrenaline do? It makes your heart race. It raises your blood pressure. So the amount of blood going into your kidneys increases. The volume going per minute increases. And you know, whichever blood goes through your system, the kidney will drain some fluid from it, won't it? So basically, the tachycardia that you get, the racing heart, the hypertension you get, affects the kidneys to produce more urine. And therefore, you're more likely to get up. So frequency is relatively common in patients with obstructive sleep apnea. So it's a symptom worth thinking about. Okay, we've probably done that to a death, haven't we? Does everybody sort of understand how a multitude of tissues and organs can be affected by obstructive sleep apnea? You now understand?
Yeah.
Good. Right. Now, if If 20% of patients or people in any population snore, okay, so 20% in the UK would be how many? 15 million people. You're not going to be able to see 15 million people, are you, for sleep studies? It's impossible. So you must have some way of triaging those that might have obstructive sleep apnea. So I'm going to show you a triage system. It's called the Stop Bang Questionnaire. Anybody come across it before?
No.
Okay. It's called Stop Bang, not because somebody thought of a very fancy title. It's just that stop and bang, as you can see on the left here, indicate the items that you need to grade as positive, present or not present. There are a total of 8 questions, so it's very easy. It's much better than the Epworth Sleepiness Score. Have you come across the Epworth Sleepiness Score?
Yeah.
What about our colleagues from the International Hub, Sharjah? Anybody come across Epworth Sleepiness Score? Well, maybe you ought to look it up. That's the one that's commonly used. But people who are insomniacs will have a very high Epworth Sleepiness Score, but they don't have obstructive sleep apnea. This Stop Bang Questionnaire was devised by an anaesthetist. Okay, and it's specifically for obstructive sleep apnea. So, is there snoring present? Whoops, sorry. Apologies. Is there snoring present? And if the answer is yes, you tick 1. And the partner might say, even when the door's closed and I'm sleeping in the bathroom, or he's in the bathroom and I'm sleeping in the bedroom, I can still hear him. Or we have to have 2 or 3 rooms adjacent to us in hotels when we go on holiday. So snoring is loud, but it's there. Is there tiredness, particularly daytime tiredness? Are you tending to fall asleep after lunch, while driving, while watching television? You know, these things that I've mentioned to you? If that's positive, that's another score. Are there any observed struggles or obstructions? So does the partner, your mistress or your lover, whoever you sleep with, have they observed you struggling away, struggling, you know, periods of silence and struggle? If that's been observed, that's an extra score. And remember I mentioned blood pressure is frequently raised in patients with obstructive sleep apnea. So if they have high blood pressure which is under treatment, that's another positive. A BMI of 35 or above, you score an extra 1. Age, 50 or above, for a variety of reasons. And if you try and go back to the very first slide, which was that sagittal section of the head and neck, all the muscles that sort of keep your airway open, as you get older, they just become more lax. Okay, not the tone goes. So at night, the chances of them collapsing are that much higher. And as you get older, the incidence of snoring related to that goes higher. So if the patient is aged 50 or above, score another positive. We also know that neck circumference of 16, 16.5 or above, there's an increased incidence of obstructive sleep apnea. Now, that's because fatties are laid down in and around the neck. I think there was one of our colleagues that mentioned earlier on about various parts of the body that fat is laid down. Fat is laid down in the neck, but not only externally, it's also laid down internally. So the potential to have obstructive sleep apnea in people with large necks is that much higher. As far as the gender is concerned, you score 1 if you're male. Now, the women might laugh at this. Women generally do not have a great issue with obstructive sleep apnea until they become post-menopausal. Somehow the female hormones seem to protect the majority of patients, majority of females, from obstructive sleep apnea. However, after the menopause and with age, they generally within 2 or 3 or 4 years, they catch up with the same incidence of obstructive sleep apnea as males. Now, what we said earlier on, do you remember what AHI stands for? Asthma. Asthma? You there?
Yes.
What does it stand for? Apneic, hypopneic index. Remember I mentioned it? That's the number of apnea episodes and the number of hypopneic episodes. Apnea is 10 seconds or more of no air moving, and hypopnea is when the airflow, which is like this, goes to 50% of normal, right? If you add the two scores together, you get the apneic hypopneic index. Everybody clear? Who's not clear? Okay.
Sorry, it was
Sorry?
the apneic. So it's number of episodes per
Hour.
times by the number of seconds.
No, it's just additive. How many apneic episodes do you have in 60 minutes? And how many hypopneic episodes do you have in 60 minutes? Add the two together and you get the AHI score. Apneic Hypopneic Index score. A very important score. Okay? Now, is everybody clear on that? Okay. Normal people, I don't know what normal is, but apparently normal people can have 5 or less, a score of 5 or less of AHI per hour. So if your apneic hypopneic index is 5 or less, that is normal. We're all entitled to 5. Okay? If you have an AHI score of 5 to 15 episodes per hour, that's known as mild obstructive sleep apnea. This generally doesn't give you all the symptoms that we mentioned earlier on. A bit maybe loud snoring, minimal if any tiredness, a little bit of grumpiness, nothing terrible but still snoring. These patients with an AHI score of 5 to 15 usually need lifestyle changes and maybe a little bit of mandibular advancement device, which I'll come to in a minute. If the AHI score is 15 to 30 episodes per hour, that is moderately severe. These patients will run into medium and long-term problems. They will have increasingly severe symptoms that we mentioned earlier on. And they will be tired, majority will be tired, and they will need something a bit more active, which we'll come to. And an AHI score of 30 plus is severe obstructive sleep apnea. Now, I've seen scores of 60 and 70 and 80. Can you imagine 80 episodes of obstructive sleep apnea, obstruction or hypopnea every hour? Basically, you're not sleeping at all, are you? It can be that bad. The stop-bang questionnaire will pick up, with the scoring system, 84%. So if you get 4 or above score, 4 out of 8, you're going to have at least mild obstructive sleep apnea. It will pick up the moderately severe in 93% of cases, because they definitely will have a score of 4 or above. And the stop-bang questionnaire will pick up all patients with severe obstructive sleep apnea, because their score definitely will be above 4. The mild, 84% will get picked up by the stop-bang questionnaire. Still a pretty good hit. Okay? The people with the greatest risk are those with scores of 7 and 8, and then you get a decreased risk with 5 and 6 and 3 and 4. So if you really had services where the resource was small, you might try and stratify the patients you see with scores of, say, 5 and above, or 6 and above, and not worry so much about patients with scores of 3s and 4s. So is everybody familiar with this? Now, happy with this?
Yeah.
Anybody not happy?
Just a quick question.
Yeah, sure, fire away.
So you've got your AHI score.
Yeah.
The number of apneic episodes is the number of times you stop breathing 10 seconds. The hypoxic episodes, you have to sit there with a tap on.
No. What it is, the hypopneic, I haven't got I should have a slide of the bit of kit, but the bit of kit that you use, and you can do this as home sleep studies, you have a little oximeter, and you have a little probe up here on the neck, and you have another little probe, and these 3 probes will measure the airflow, the rate of airflow, so it can detect when it goes to 50%. It will detect snoring and the intensity or the loudness of snoring. It will detect your oxygen saturation with the oxygen meter. And there's a special probe that measures arterial tension, and that tells us what position you're in. Amazingly, what position you're sleeping in, and also what stage of sleep you're at. Because remember, sleep starts light. Can you all see me?
Mm-hmm.
Sleep starts light. You get into deep sleep, deeper sleep, and then you get into REM sleep, and then you come back out to light, deep sleep, light sleep, and then you go into another cycle of light, deep, deeper, REM, then back out. And one cycle lasts about 90 minutes. You need about 3 to 4 of those cycles per episode of sleep. The piece of kit that we use measures what stage of sleep the patient's in. Now, you can imagine if you're light sleeping and then you go into deep sleep, you need to get into REM sleep to reboot your brain. But if you're deoxygenating, you wake up, don't you? You have an arousal. And so you go into deep sleep and you come back into light sleep. You're trying to get into deep sleep, you obstruct, you come back, bounce back into light sleep. You may get a little bit of REM sleep, but not as much as you should. That's why your brain gets frazzled with obstructive sleep apnea. So do you understand the cycle of sleep?
Mm-hmm.
And you understand if you don't have the full cycles and you keep bouncing from deep into light sleep without going too much into REM sleep, it will affect you mentally. Okay? Does that sort of answer your question, Daniel?
Yes.
Okay, good. Okay. I don't actually, unfortunately, have a picture. Next time I'll put a picture of the bit of kit. That would have been useful to have, but I didn't think about it. So if you do a sleep study, so say they've got scores of 7 and 8. You do the sleep study. This is the sort of thing you might get, the results. This is a summary of what you might get. So the piece of kit will tell you whether you were asleep or you were waking. If you get up in the middle of the night and you've got this kit on, it knows you're awake. It's a very clever algorithm. So in order to do a sleep study, you need at least 4 hours of sleep. Otherwise, the results are a little bit meaningless. You must have a minimum of 4 hours of reading while you're asleep. So most patients manage 4 hours. Okay, so it tells you, in this instance, the patient seems to have, 80% of the time is asleep, and he had something like 6 hours sleep. Here, it tells you what stages of sleep you were in, the patient was in. So this patient was almost 80% in light sleep. What's the normal amount of light sleep that you should have? Synapse. If you're sleeping, what sort of percentage of your sleep should be light sleep? Somebody else shout.
50%.
How much?
50%?
Yeah, exactly. Almost 50%. Just 50% should be light sleep. Okay, Saida, what about deep sleep? This patient's got about 10% deep sleep. What should the percentage of deep sleep be? Have a guess.
Around 50, at least around 50%?
Well, you can't have 50% light sleep and 50% deep sleep, because then you're going to have no REM sleep.
Okay, so 30%?
Yeah, it's about 25%. 25 to 30%. And Tanusha, what about rapid eye movement sleep?
So 20 to 25% then?
Yeah, you should have about 25% of REM sleep. So basically, half should be light, and what remains, half should be deep and half should be REM. About 25. This patient has much less than 25% REM sleep and much less than 25% deep sleep. Okay, so there's an issue here already. If you take this pie chart, this tells you the position the patient was in. P means prone, that's on your back. So he spent over 50% of his time on his back. And about, 40% supine on his front, and about 10% or so on the right-hand side. Daniel, why do you think the prone bit is important?
Because
or not important?
Your soft palate, your tongue is more likely to fall back?
Absolutely. So patients, their spouses, partners will tell you that their snoring and their struggle is much worse if they're on their back. And they're forever trying to get them on their side. And what's even better is not on your side, but actually on your stomach, forwards, supine. Does anybody know anybody who sleeps on their belly? Anybody know that?
No.
Okay. Are there any mothers in the audience?
Yeah.
Have you ever known mothers with little children who have a bit of a struggle breathing on their back? And they lie them forward, don't they? They put them on their belly, don't they? To help their breathing. Have you noticed that?
Yes.
The reason is the same as adults, that the tongue and the tonsil and everything else will fall forward, and therefore the airway will open up at the back. And you have some adults who just sleep on their stomachs, because they find that's the most comfortable position where they get a reasonable night's sleep. Okay? So asking the wife whether they sleep on their back or their front is quite important. Now, if you take the parameters of a sleep study, it's diagrammatically put in a histogram here. So the AHI score in this patient over the period of study was 66 episodes per hour. Is that mild, moderate, or severe obstructive sleep apnea?
Severe.
That is severe obstructive sleep apnea. In fact, he had 522 episodes of apnea and or hypopnea during the sleep period. Now, this score here, ODI, is called the Oxygen Desaturation Index. We know the oxygen desaturates, don't we? Yeah? Everybody, we know why the oxygen desaturates. In you and me, we can have up to 5 episodes of desaturation an hour, and it's considered normal. So think about that, 5 episodes per hour. Now, an episode is classified as a 4% drop in the oxygen saturation. So it could go from 99 down to 95. That would be considered 1 episode. So everybody happy with that? Okay. Everybody happy with that?
Yeah.
Yeah. Now, if you try and hold your breath, and I want you all to do this, as long as you can, we'll do it in a second. I'm going to give you about 5 seconds, and then hold your breath as long as you can. So ready? Everybody ready?
Yes.
Okay. If you can hold your breath as long as you can, and try and time how long you can hold it for. So go now. I want to hear a lot of huffing and puffing when you start rebreathing. Somebody's already given up. So shout your name out when you start rebreathing, so I know you're still alive. Who's that? Who's laughing? Deepa.
Yeah. Yes, sir.
Fine. Okay. Is there somebody still holding their breath? My God, that's not bad. Okay, Tanusha, are you still alive? Tanusha?
Yeah.
Okay, Ada?
Yeah.
Okay, you're right. Okay. All right, is everybody rebreathing? Is nobody stop breathing, please? I don't want to death on my hands. Okay. Everybody rebreathing?
Yeah.
Yeah.
Okay. When you held your breath for as long as you can, your oxygen levels went down by 2% only. Think about that. An oxygen desaturation episode is actually double that, 4%. So imagine holding your breath for twice as long as you did. That is not nice, is it? No. That is not nice. So this particular patient, he had 4% or greater drop. It could have been a 10% drop, it could have been a 15% drop, but more than 4%, 60 times an hour because of obstructive sleep apnea. Okay, so does everybody understand that now?
Yeah.
So if you have 5 of those or less, that's normal. If you have 5 or 15 ODIs, that is mild. If you have 15 to 30, that's moderately severe. If you have over 30, that's severe. Okay? Same as the AHI. Now, if you take respiratory distress index, respiratory distress index. Now, what that is, now listen very carefully, is that is when your brain has an arousal thinking you're going to obstruct. You may not obstruct, but you may be almost obstructing. So, in very young people, when the airway starts to narrow, what would you do in order to try and get air into your airway when it's narrowing? You would just work harder, wouldn't you? To keep it open, right?
Yeah.
You all understand that?
Yeah.
Okay. When you're young and fit, if you're going to obstruct, you might work very hard, breathing-wise and everything else, to keep your airway open. But your brain notices you are beginning to obstruct, but you don't quite do it. So this sleep study kit measures that. So when you're very young, you may not obstruct. You may only have a few episodes of apnea or hypopnea, but you have lots of arousals. So in very young people, you have a thing called an upper airway resistance syndrome. So you don't quite obstruct. You might snore, but you don't actually obstruct. But your respiratory distress index is high because you're getting the arousal as you're narrowing without obstructing, but the brain arousal is picked up. You understand? Yeah. So a high RDI may mean you're not obstructing yet, but the moment 5 years down the road, you will be obstructing badly. So supposing you had upper airway resistance syndrome for 6 or 7 hours a night, as your airway is narrowing, you're working much harder. So physically, you're working very hard. So what happens in the morning when you wake up? How do you feel?
Tired.
You feel bloody exhausted. And I work in London, in central London, quite near the city of London, and there's lots of very young financiers and people in banking, okay? And I've had patients who are 25, 26 who say, I wake up in the morning, I'm absolutely dog tired. I can't concentrate on the numbers, I'm making mistakes. You do the sleep study and their AHI score is not very high, but their RDI is greater than 5. It may be greater than 15 or it may be greater than 30. The parameters are the same, by the way. Less than 5, 5 to 15, 15 to 30, more than 30. Now, in this patient, if you look very carefully, the RDI is almost the same as the AHI, right? And that is because they don't have any episodes where they're keeping the airway open. Every time it's going to narrow, it collapses. So in severe obstructive sleep apneics, the RDI and the AHI is almost the same. So the brain is being aroused 66 times an hour because they're obstructing 66 times an hour. You understand? Mm-hmm. If they're obstructing 10 times an hour, but they have an arousal of 30 times an hour, that is still significant because they're young, They're not obstructing, but they're struggling. So they wake up absolutely exhausted. All right?
Yes.
So everybody is now familiar with how you read these things?
So sorry,
Yeah.
30 plus AHIs is severe obstructive sleep apnea.
Yeah.
Would 30 RDIs be severe obstructive sleep apnea?
Well, it's not obstructive sleep apnea. It would be called almost certainly upper airway resistance syndrome. So if your AHI score was low, say only 5, you've got to take that score, which is low, with relatively high RDI and say there is still a problem. It's not obstructive sleep apnea, but the symptoms end up being the same because the patient is working so hard to keep their airway open. And they probably need the same sort of treatment. So don't get fooled if the AHI score is normal or near normal or only mild. You must also look at the RDI and also the ODI. Okay, so never trust one single investigation. Does that make sense? Yeah, good. Okay, why is all this important? Well, supposing your spouse, your uncle, had an obstructive sleep apnea. If you look at the upper curve here, upper graph, this is a study done in 2005. If you take 12 years worth of apneics, obstructive apneics, okay, 144 months here, 0 here. If you're a severe obstructive sleep apneic, this is this red line, 15% will drop dead within 12 months. Okay?
Mm-hmm.
Everybody understand that?
Yes.
If you are a mild, you know, you still got a 5-7% chance. Okay? If you're a control, you know, some people will drop dead, but it's only, you know, half or 1%. If you take the severe obstructive sleep apneics and put them on CPAP, continuous positive airway pressure, they come down to the blue line, which is normal. You can stop 10-12% of these patients from dropping dead. They will drop dead. If you have severe obstructive sleep apnea over a 12-year period, 15% will drop dead. Okay? If you treat these patients, they revert to the normal curve, which is the blue line. See the blue line?
Mm-hmm.
Okay? And the controls are the green line. I mean, it almost is normal, right? So there's a very good reason for treating severe obstructive sleep apnea. So you stop 15% of them dying. Well, what's worse than death, ladies and gentlemen? Tell me. Severe disability, so your quality of life is an underpants. Okay, it is awful. So, if you take now the lower graph, if you take severe obstructive sleep apneics, 30% here, this red graph, 30% will have a non-fatal problem, either a heart attack, which leaves them disabled, or a stroke, or something wrong with their kidneys, or something that makes them basically disabled. So what's worse than death is actually a severe disability. So you're dependent on your family, you're dependent on the state, you can't fend for yourself, it's bloody miserable. Okay? However, if you treat severe obstructive sleep apneics with CPAP, here we are, you go to the blue line. You revert to normal, pretty much. A huge improvement. So what's the reason for treating obstructive sleep apnea? Is to stop people dying, and worse still, is to stop them having a severe disability. Do you know what the cost of a severe disability is in your country? It might amount to 100 grand a year, £200,000 a year in total economic, not to measure the psychological costs. Okay? So although snoring is a symptom, it's only the iceberg of what's going on underneath. And although we mostly laugh about people that snore, it's actually a symptom of some potential underlying problem. So remember that. So, if we take quality of life, and we measure physical function, limitation of what you can do, generally how you feel, the amount of energy you have, how you interact socially, emotionally, and your mental health, the general population is up here, okay? If you have epilepsy, you're here. It's not very nice, but you can sort of cope, okay? If you have Parkinson's disease, you're down here. See this mauve line? If you have obstructive sleep apnea, it's almost the same as having Parkinson's disease in terms of your quality of life. So your quality of life with obstructive sleep apnea is not very good. That's another reason for helping patients. I've mentioned the costs, but we don't need to go into too much detail in the costs. So, what is the... Sorry, what's happened there? It didn't go forward. Could not be found, okay. Can we go to the next one? It didn't go here for some reason. Can we jump one, Sean? Hmm? Well, I can't get the next slide. Treatment. Okay, sorry. Sorry, here we are. I'm not a technical whiz kid. So, NICE has various guidelines about what you should do, okay? There's lifestyle changes, lose weight, stop smoking, watch your diet, blah-de-blah-de-blah. Everybody does that. For mild obstructive sleep apneics who are not tired, lifestyle changes with a mandibular advancement device. Remember, the only bit of your jaw that can move is your mandible, isn't it? And what's attached, what significant organ in your mouth is attached to the mandible? Tongue. Everybody aware of that? Asthma? You know your tongue is attached to your jaw? That's why anaesthetists get hold of your mandible and push it forward to stop the tongue falling back in your throat. So a mandible, somebody needs to put their child to sleep. So for mild obstructive sleep apneics, if you bring the tongue forward wearing a mandibular advancement device during the night, it might resolve the problem. However, if they're tired, you may need other types of treatment. A proportion of patients, and all these patients should really be seen by ENT, because remember, which part of the airway produces snoring and obstructive sleep apnea?
Upper airway.
The upper airway, and who are the people that look in the upper airway?
ENT.
From nose, back of the nose, the throat, right down to the larynx, only the ENT surgeons. Because occasionally you find within the upper airway large adenoids, or even a tumour in the postnasal space. Rare. You might find large tonsils. You might find a cyst on the back of the tongue. You might find a laryngeal cyst, in which case, instead of going down CPAP and all this route, you do straightforward surgery usually, tonsils or tonsils and adenoids in children, and it cures the patient. If you're in America, they might offer to cut bits of your tongue. They may offer to break your jaw and bring it forward. They may want to do huge surgery on your palate. It may be that it stops you snoring and having obstructive sleep apnea, but talking and eating and everything else is much more difficult, and there's no guarantee of success. So all the heroic stuff I do not do, and most of the people in the UK do not do. About 90% of children with obstructive sleep apnea will get cured with tonsils and adenoids. About 10% of patients, adults, get cured because they have large tonsils. I would not do any of the heroic stuff surgery.
Do you remove soft palate at all?
Even the soft palate, okay, it hardly makes a difference, because you know what happens? You maybe shorten the soft palate, you may even cut bits of it off, but you know what happens to the tension that's produced in tissue in the body? After 2 years, the tension returns back to normal. It's like having a fresh scar. Everybody must have cut themselves. When the fresh scar is there, it's quite hard. But after a year or two, it's soft. You don't notice any difference compared to the adjacent tissue. Okay?
Why do they offer it for snoring then?
Well, it's no good for obstructive sleep apnea.
Yeah.
Okay? It might marginally help just what we call simple or social snorers. They don't have obstructive sleep apnea. Okay? Surgery is sometimes in adults combined with tonsillectomy. That you can do. Okay? But palatal surgery on its own, after 18 months to 2 years, I've done it all. For years I used to do this. I pretty much don't do it anymore. Now CPAP, this is a mask on your face or your nose and or nose and mouth, which basically blows air under pressure into your airway. And it keeps everything open. Okay? Everything open at night. Because what the body needs is not oxygen. There's plenty of oxygen in air. You just give them air. It's air they're lacking. And CPAP in severe obstructive sleep apneics or moderately severe who are tired, or even the mild who are tired, works like magic. Because the sleep deficit, because if you wake up all the time, the body has a sleep deficit. You've got to pay that deficit back. You're going to have to sleep sooner or later. So in 2 or 3 days of CPAP, the patients notice a dramatic difference. They're more lively, they wake up refreshed, they don't have early morning headache, they're much more energetic, they'll go to the gym, and the lifestyle completely changes. However, they have to wear this mask on the nose or mouth. If they're tired and exhausted and it works, it's like an addiction, they love it. But about 10% of patients who would benefit from it can't actually use it. So you have to try other methods, mandibular advancement devices, possibly some surgery, much more lifestyle in trying to lose weight. But CPAP can be like magic. And if you have obstructive sleep apnea, if you use it, you can still keep your license, your driver's license. Okay, any questions on obstructive sleep apnea?
So what surgery could you use in adults who don't have large tonsils or tumours?
Well, it's the heroic stuff.
So virtually nothing in the UK then?
Very few people will be doing that. You might get the oddball max fax person who's completely mad surgeon who might do it. You have to try and get them on CPAP. The secret of CPAP is the first 6 to 8 weeks. If you can get the mask fitting properly and they're happy with it and you get lots of support, they will use it. So in my hands and my colleagues that I work with, instead of 80% benefiting, we get 90–95%. Okay, the others you might have to duck and dive a bit. Okay, there are various balls you can put in your back. There are various palatal things that as you start snoring and obstructing it wakes you up. I mean, they're all, don't work that well. Okay, you need good support for people who've got severe obstructive or moderately severe for using CPAP. That's what you need to aim for. Okay, and it's very important in this situation to have not just the sufferer, the one with obstructive sleep apnea, but also their spouse, because they can be very supportive. Okay, and I tend to see patients with their spouse. So men, if they come and see me alone first, I tell them next visit, bring your wife along, or your partner if they happen to be, homosexuals. Bring your partner along. So because you're treating both, in effect, treating both people. Any other questions? Zani, Khadija, Shakiba, Asma, any other questions? Saida, Danusha, yeah? Shout, please.
CPAP, is it useful for large tonsils? Well,
no. Look, you can use CPAP in patients who have large tonsils, and that's what happens with respiratory physicians because they don't look in the mouth. In the UK, there's probably hundreds and hundreds, if not several thousands of patients who went to respiratory doctors for snoring, potential obstructive sleep apnea, who've been put on CPAP, who could be cured. If you don't can't afford the surgery, or you live in an area where it's not possible to do tonsillectomy, then CPAP is very effective even in patients with large tonsils. Yeah. Does that answer your question?
Yeah, thank you.
Okay, Khadija. Any other questions?
DVLA,
Yeah.
you only have to inform for taxi drivers or lorry drivers, is it?
No, anybody.
Anyone?
Yeah. Anyone. If you've got the diagnosis of obstructive sleep apnea, you need to inform the DVLA. And you then need a letter that if you're mild or whatever it is, you need to tell them what treatment you're having. If you're a severe obstructive sleep apnea, you've got to use at least the machine for 4 hours a day, 4 hours a night. I think it's 70 or 80% of the time.
Okay.
So not every day. So there's a criteria, and they say if somebody's can vouch for that criteria that you've used it, you're able to drive. So lorry drivers don't have to lose their licenses, provided they comply.
Yeah.
The DVLA want. Because one of the reasons lorry drivers don't come to you, they're worried about losing their licenses.
Yeah.
Yeah.
Okay, yeah.
Any other questions? Okay.
I just had a quick question just about the hypopneic episodes. When you said it's where the airflow reduces by 50%, and that's monitored by the sleep study. But is that over a particular time period as well? Is that like?
Yeah. No, you never measure hypopnea on its own.
Uh-huh.
You always aggregate the apneic episodes with the hypopneic episodes and get an AHI score.
So it's where it's apneic and hypopneic together.
Yeah, that's what
so
the AHI means, yeah.
Okay, so that's still over 10 seconds then?
No, the apnea would be 10 seconds, but any episode where the flow is less than 50%.
So whether it's a second or 2 seconds?
Well, yeah, it's not. I think there is a time limit. I can't remember. Actually, nobody's ever asked me that question. I'll have to look that one up. The answer is I'm not entirely sure. But
okay.
there must be a limit, because you can't do it for 1 second. It probably is 10 or 15 seconds.
Okay, because I just wasn't sure if it was over the same time period or separate time periods. Because obviously when it's the AHI, you're adding them together.
No. Look, you can't have an apnea and an hypopnea at the same time.
Yeah. Because one is no air moving and one's reduced.
One is nothing, the other one is
reduced.
Something.
Yeah.
Yeah, so it's the aggregate scores. So it probably, I'm not sure what the algorithm actually measures on the hypopnea. I should know. I should know the definition of a hypo. I think it's probably over 10 or 15 seconds that there's a 50% reduction.
Okay.
But it's actually, the detail for you is not important. The important thing is there's an aggregate score of these episodes. And more importantly, if you want to explain it to patients, you can explain that. But I think the ODI is an actually very good practical way of explaining, how severe things can be. Any other questions? Okay. Does everybody want to just go for a 3-minute comfort break if you need it? You want to go and use the WC toilet, and then we'll do about another 20 minutes because you've probably had enough, haven't you? Yeah? Everybody happy with that?
Yeah.
Yeah. Okay. We reconvene in about 3-4 minutes.
Okay.
Okay. You want to turn on? Right, hello, sir. Everybody back?
Yes.
Okay, Christian is there as well. Christian, are you there?
Yes, I am.
Good. You joined us slightly late. Hopefully you got the latter half of my talk on snoring and obstructive sleep apnea. The big issue around UAE and the Middle East. Okay, look, I'm going to do another sort of 20 minutes or so, because it's been concentration levels start going. I'm just going to do a little bit just sort of more generically. So look, patients present with a lump in the neck. Everybody see that?
Yes.
Okay, lump in the neck. If you want, I mean, you obviously asked about symptoms, but if we just go back to the sort of pathology a little bit, a lump in the neck, how would you classify what that lump might be?
Midline or lateral?
You could do midline or lateral. Any other way of doing it?
The node levels?
Well, we don't know it's a node, do we? So first of all...
The triangles?
Well, that just tells you location. Well, you could do congenital acquired. You know the congenital acquired one? Congenital is prenatal, natal, postnatal, and the acquired is inflammatory, cancer, degenerative, connective tissue, autoimmune, you know, all this sort of stuff. Remember that from medical student days?
Yeah.
The other way, what's the other sort of more practical way of doing it? You see, this is a symptom, isn't it? A lump in the neck is a symptom. So if I have a cough, I could say there may be local causes of a cough in my throat, or there may be more distant causes of cough, which are not in my throat. It could be due to drugs. It could be due to diaphragmatic stimulation. It could be due to gastroesophageal reflux. You understand? So usually with lumps and symptoms, who's got their child there, please? Can we? Hello? Excuse me. Who's got their child? Can we not have the child in the same room, please? You're disturbing everybody else. Thank you. Right. So when you've got a lump in the neck, you think of local causes of a lump in the neck and more distant causes, systemic or distant causes. So if you were going down the local causes of a lump where this is around near the angle of the mandible, isn't it? Yeah? Here's the mandible, and here's the lump, yeah? Okay, so, Christian, if I ask you about local causes of a lump here, what tissues would you be thinking of?
Lymph node enlargement.
Okay, in this area, you're going to have lymph nodes. Okay, could be a lymph node. Anything else? It could be to do with the skin, couldn't it? Skin is there, isn't it?
Yeah.
Yes.
And what's under the skin? Fat. So it could be something related to the fat that's produced this. What else have you got in this region?
Muscles.
Sorry?
Muscle?
Muscle? It could be muscle. What else have you got in here? Anybody?
It could be cyst.
Which one?
Cyst.
Cyst.
Yes.
No, that's the diagnosis. What other tissue have you got in here that the lump may arise?
Tissues.
Which ones?
Tissues.
Which one? Well, there are blood vessels there. There's nerve tissue. There's lymph nodes. There's lymphatics. Okay, there's skin. There's muscle. There's fat. So this could be arising from any of those. Okay?
Yeah.
So whenever you get lumps or lesions, you think local, or is it caused by some more distant or systemic effect? Okay? So if you get a rash on the skin here, it could be due to a local cause, or you may have an infective gut or something that manifests itself with lesions in the skin. You understand?
Yes.
When it comes to symptoms or presentations, think of local things and more distant things, okay? Now, the distant ones are almost certainly going to be what? Sabrina. Not Sabrina. Rachel. What's the one that would worry you? What's going to produce a lump here coming from somewhere else?
Maybe metastatic.
Yeah, the only other thing really you need to think about is metastatic disease. Okay? So a lump in the neck is either due to local causes or it's due to more distant causes. Now, local causes, it's easy to work out. Now, if this has come from somewhere else, metastatic disease is a possibility, but look at this patient here. Do you see anything here?
Skin rash.
Looks a little bit infective, doesn't it?
Yeah.
So it could be not just distant metastasis due to a primary elsewhere, it could be a skin or infective lesion that is producing lymphadenopathy here. All right?
Yeah.
So if you think this is a node, is it a local problem like lymphoma, or is it coming from somewhere else, a primary malignancy or an infective area that is drained by this area, is drained by this node? Okay? Now, let's assume this is a malignancy in the neck. So, Khadija, where do you think this malignancy might arise? It's high up in the neck. It's metastatic. We think it's metastatic disease. What are the sites you might be thinking of that it might have arisen from? Sorry?
A liver gland.
Which gland?
A liver gland.
It could be a saliva gland. They don't normally metastasize apart from very rare adenoid cystic. A parotid gland normally would be here. It's unlikely to metastasize, but it's worth thinking about. Submandibular gland would be a swelling here. Okay. Okay, I will put that lower down on the list. What about you, Sakiba? Where might a malignancy arise from?
Carotid body tumor.
That's a local one. That's local, isn't it? There's a carotid body in here, not quite so high, probably lower down.
Tonsil?
Yep. Tonsil, very rich in lymphatics. You may have virtually nothing in the tonsil, but it presents as a lump in the neck. Any others?
Thyroid.
Sorry?
Thyroid gland.
Yeah, thyroid gland, again, can give you a lump in the neck. Usually not this high, but very good suggestion. Seems to be a bit lower and a bit more lateral, but yep, thyroid. Anything else?
Parathyroid gland.
Which one?
Parathyroid.
Thyroid. We just mentioned thyroid. Somebody's already mentioned thyroid gland. Any other area?
Parotid gland.
Parotid?
Parotid gland.
Hang on, somebody else I didn't quite catch that.
Parotid gland. Parotid gland.
Oh, parotid gland or parathyroid?
Parotid gland. Parotid.
The parotid gland, I mean, you can get malignancies in the parotid gland, but it's not that common. Okay, that's a possibility, but it's low down the list. Where else would a metastatic node here have come from?
Base of tongue.
Tongue base, very common. Tongue base. Again, rich in lymphatics, and it metastasizes to the neck. Anywhere else?
Lungs, carcinoma of lungs.
Lungs can give you metastatic disease, absolutely right. But it tends to be lower in the neck. But worth considering, you deserve a point for that. So, squamous cell carcinoma of the lung may present in the neck. Anywhere else?
Does the nose go to there?
Sorry, hold on. Yeah, one at a time. Sorry, Daniel.
Does the nose go to there?
The nose, yes. That's a possibility, but not that often. Again, it's lower down in the list.
Okay.
Larynx.
Lymphoma.
Somebody who said larynx?
I said larynx.
Zainab, yeah. Zainab, yeah. Yeah, the larynx, not the actual true vocal cords, because they don't have any lymphatic supply. But if a tumour affects the supraglottis or the subglottis, or it goes beyond the vocal cords laterally into the muscle, then it can metastasize. So larynx. Any others?
Blood cancers like lymphoma.
Lymphoma.
No.
Lymphoma.
Lymphoma is a primary one here. It hasn't come from somewhere else. Remember, we said we're looking at metastatic disease. A lymphoma can present like this, but it's a primary thing related to the node itself. It hasn't come from somewhere else. So we've got tongue, we've got tonsil, we've got larynx, we've got lung. We had one or two others. What others? What other sites?
Sorry, where did
stomach.
Sorry, stomach. Yeah, stomach can also metastasize to the neck. Usually a bit like lung, lower down, not this high, but that's a good suggestion. Daniel?
Where does the scalp drain to?
The scalp does drain here, and also the back of the neck. That's a possibility. But again, I would put that lower down. Any other sites?
Trachea.
The trachea, yes, but again, lower down. The let me put you out of your misery. Postnasal space, the nasopharynx, very rich in lymphatics. A small lesion there can metastasize to the neck. Okay, we've said the tonsils, we've said the tongue. The hypopharynx and piriform fossa, you know the upper bit of the pharynx? That's also very rich in lymphatics. Lesions there, which could be the size of a cherry, may not produce dysphagia, because remember the pharynx is it has a space, a potential space to grow. So dysphagia may not occur early on, but a neck node might. Okay? We've mentioned the stomach.
Yeah.
So there are things above the clavicle. There are primary sites above the clavicle where a primary malignancy may present with a lump in the neck. So that's nasopharynx, it's tonsil, it's tongue, floor of mouth, thyroid. They're the main ones. Below the clavicle, you can get metastatic disease to the neck. Now, you've already mentioned the lung and the stomach. What other sites might produce metastatic disease into the neck?
Ovary.
Which one? Anybody?
Cervix. Cancer of the cervix.
Cervix can do it. Yep. Anywhere else? Anything else?
Liver.
Usually not. cervix. Yep. Somebody was going to... Breast. Breast, yep.
Yes.
Anything else?
Liver.
No, liver we said is unlikely. Wouldn't be the first thing to come into your head, shouldn't be.
What of pancreas?
Usually not the pancreas. Any others?
Do the kidneys go up?
Kidneys, yep. And what's on top of the kidneys?
Renals.
Suprarenals or adrenal glands. Kidneys and suprarenals. Anything else? Well, we mentioned the testes, did we? Testes and prostate. So what do you notice about the tissues from which metastatic disease below the clavicle can give you neck nodes? It's the stomach, the breast, the lungs, the prostate, the testes, the kidneys, the adrenals, and the cervix, and the ovaries. Sorry, the other one is the ovaries. If you draw a body, these organs are represented on both halves of the body, aren't they? Breasts, one on each side, lungs, one on each side, kidneys, one on each side, adrenals, one on each side, prostate lobes, one on each side, cervix, half and half, ovaries, half and half, testes, half and half. And the stomach, where did the stomach start in the embryo? In the midline. Remember? Do you remember your embryology?
Yeah.
So it was in the midline, and then it sort of did the turn and to lie in its, normal position. But it was originally the same. It was a midline structure, symmetrical on both sides. So if lumps are going to occur in the neck due to metastatic disease below the clavicle, those are the 5 or 6 tissues you need to think about. If you think it's above the clavicle, which is far and away the most common site for metastatic disease in the neck, you've got to think postnasal space, tonsil, tongue, floor of mouth, larynx, and thyroid. Does it all make that clear? Everybody happy with that?
Yeah.
Okay. What about laryngeal pathology? Tell me how laryngeal pathology might present. Let's start with you, Tanusha.
Presentation. I guess changes in voice.
Yeah, okay. Change in voice. So this is not just one day okay, 3 days okay, 1 day for 2-3 minutes, half an hour, and then okay for another 4 or 5 days. Okay, laryngeal pathology of any note, particularly you're thinking of cancers, okay, they will have a constant change in the voice, which may become progressively worse. It usually does not vary. So hoarseness is very important, a change in voice. Okay, what about you, Saida? Another symptom of laryngeal pathology?
Pain, so a sore throat or...
Yeah, you might get pain. It's not usually a symptom until rather late, but you may have pain or discomfort. Okay. Daniel? A feeling of something in the throat. That's, again, will tend to be late, probably. Usually not the larynx. It's something on the tongue that produces that. Because you don't really use your larynx for eating, do you? Use it for?
Voice changes.
Well, voice changes we've got, hoarseness. Okay. What else do you use your larynx for? What else happens around your, in and out of your larynx?
Difficulty in speaking?
That's hoarseness. So change. Yeah, sorry?
Breathing.
Breathing, yes, of course. Breathing, again, there may be little difference with a small lesion, but as it gets bigger, you're going to have breathing, respiratory difficulties, maybe even stridor. Okay, what else? When it gets bigger and goes into the pharynx? Rachel. Supposing the laryngeal lesion has got bigger and it's encroaching on your pharynx, what might you get?
Choking.
Choking, or before choking? What do you use your pharynx for? Somebody?
Dysphagia. Dysphagia.
Yeah, you may have difficulty swallowing. Dysphagia. Okay. What else? You got a malignant lesion in the larynx. How might that present? We were talking about it earlier. Christian, tell me. Sorry? Somebody else. So, Zainab. How else might it present? Laryngeal pathology. A lump in the neck. We mentioned that earlier, haven't we? Okay?
Obstructive sleep apnea.
Okay. And then finally, let's come to Khadija. Khadija, what nerve supplies sensation to the larynx? Do you remember the cranial nerve that supplies sensation to the larynx? Sorry?
Laryngeal nerve.
Yeah. What cranial nerve does it arise from?
Number 9.
No, not number 9. What about deeper? What cranial nerve does the recurrent laryngeal nerve?
11.
No, that's the accessory nerve. That's for moving your shoulders around.
Is it the vagus?
It's the vagus, the 10th cranial nerve, the vagus nerve. Vagus just means wanderer, because it wanders everywhere. It supplies the heart, it supplies the stomach, supplies the larynx, supplies the ear, supplies back the tongue. It's all over the place, the vagus nerve. It also has the branches of the superior laryngeal nerve and the recurrent laryngeal nerve, which supplies, and also it supplies the pharyngeal nerves, which supply the pharynx for sensation. It supplies sensation to the larynx, trachea, and the bronchi. So if you have pathology in the larynx of any significance, you may get referred pain in the ear, because the larynx supplies a little bit of sensation in the ear. So altalgia, rare symptom in laryngeal pathology, but you can get it. Okay, has that been useful? I hope so. Okay, so we mentioned these: dyspnea and stridor, pain, hoarseness, dysphagia, swelling in the neck, and otalgia. Okay, so in terms of the larynx, what's the most important physical examination that you do? Let's have. What about Khadija? What's the most important examination? What do you need? What do you want to do? If I came to you with, sorry, deeper.
Laryngoscope.
Yeah, I mean, you need to view the larynx. You may need to examine the neck and all the mouth and everything else, but ultimately you've got to have a look at the larynx. And you can do this through flexible laryngoscopy. Has everybody seen a flexible laryngoscope? Put it in through the nose, and you can actually see the whole of the nose, back of the mouth, the oropharynx, and you can also see the larynx. So that's the minimum examination required. If you work in countries where you don't have flexible scopes, you might be able to use a mirror, which is the way I started 35 years ago in ENT practice. So in anybody with suspected laryngeal pathology, you need to examine the larynx. Because remember, laryngeal symptoms, like hoarseness, could be due to a local lesion in the larynx, something on the vocal cords, or it could be something away from the larynx. It could be the vagus nerve being trapped in the skull base, producing problems with the recurrent laryngeal nerve, and therefore the vocal cord is not moving. There's nothing wrong with the vocal cord or a primary lesion there. The lesion is actually in the skull base. So the reason for looking at the larynx is there a local cause for the laryngeal symptoms, or is there a systemic cause? Okay? So, this is a normal larynx. sort of a pearly white vocal cords. Okay, you can just about see the epiglottis here. See the epiglottis?
Yeah.
Okay, this is the trachea. You can see the tracheal rings. Yep. You can see the arytenoids here and here. Okay. Pharynx is this bit. This is the piriform fossa here. If you go down there into the screen, you end up in the pharynx. Just here is the pharynx. If there's an obstructive lesion in the pharynx, you sometimes see lots of saliva here, which is pooling. Okay? So that's a normal vocal cords. Oh, what's happened here now? I can't move forward. Again, shall I just do this? Oh, not working. No. Okay. If you look at this larynx, it's turned slightly the different way. Okay, let's Tanusha, what do you see here? Tell me. Describe it.
One of the cords looks very swollen.
This one, yeah.
Yeah, and inflamed, and looks like it's not tense, like not maybe.
Yeah. Swollen, irregular, looks a bit angry. The other one doesn't look too bad. You can't quite see the anterior commissure. There's probably a tube. Whose children is that? We get. Who's the one with the children? You need somebody to take care of your children when you have a webinar in future, please. So here's a endotracheal tube for breathing. So what is the doctor thinking is going on here, Daniel?
Presume it's cancer of the vocal cord?
That's what you need to exclude, okay? And the only way of excluding it is to take a biopsy, which you need a general anaesthetic for, okay? Right, okay, Saida, what about this?
Once again, there's a lot of irregularity, the cord is swelling, there's asymmetry, inflammation.
Of this cord, this one doesn't look too bad, does it?
Yeah.
Very polypoid, almost like papilloma. This could be a papilloma, but it could be a tumour. So again, you can see the airway being potentially compromised here. So this patient may have not only voice change for a long time, I suspect, but may also now be having his respiratory system compromised as well. And clearly, if this is a cancer, it almost certainly has fixed the vocal cord, so the vocal cord is not moving normally, or it's fixed, and it may have gone into the vocalis muscle, which is lateral here, and there's a risk of metastasis now. Okay? This, I think, we'll leave. What about this asthma? Christian, what is this?
No.
Sorry? What is this, do you think? Christian? Okay, asthma, what do you think this is?
Node-like structures are present on the vocal cord.
Both vocal cords?
Both vocal cords.
Where exactly in the vocal cords are they? How would you describe where they are?
On the anterior...
Well, they're on the free vibrating edge. They're not here, the superior surface, and they're not underneath. They're on the free vibrating edge. And what junction of the vocal cord are they at? That's the front third, isn't it?
Yes.
This is the posterior 2/3. They're at the junction of the posterior 2/3 and anterior 1/3.
Yeah, 1/3.
They're the classical position for vocal cord nodules, usually due to vocal abuse in teachers, singers, actors, children, okay, preachers. And you can imagine that the vibration of the vibrating edge will be compromised and they'll have a dysphonia. So is this malignant?
No.
It's pre-malignant.
Sorry?
Pre-malignant?
No, it's not. Vocal cord nodules are not malignant at all. This doesn't even remotely look malignant, does it? Why would you get 2 malignancies, one on each vocal cord? No, this is vocal cord nodules due to vocal abuse. The patient needs speech therapy, and these probably will resolve. This is because the vocal cords are being bashed together like this, because they're abusing their voice, and if you bash your hands enough, it gets very sore, and you get calluses forming on the tissue. These are just calluses trying to protect the vocal cord from being bashed about too much. So if you get rid of the bashing with suitable speech therapy, this should resolve. In the old days, people used to operate on them to smooth them out, but if the patient is still bashing them, they're going to come back in a few months. So normal treatment is to get a good ENT speech therapist to sort this out for you, get the patient sorted out. Very rarely, I think I've probably operated on one vocal cord nodule patient in the last 10 years. They all get better with speech therapy. Surgery is not necessary. Okay, what about Rachel? Did we speak to Rachel? Rachel, what do you make of this? Can you see the vocal cords?
Yeah.
Do they look like the ones I showed you right at the beginning?
No.
So tell me what appearance you see here.
I think there is
They're very both cords look, you can just about get a hint of the cord there, can't you? And a little bit there, maybe. Otherwise, there's a lot of sort of swelling, like a bag-filled fluid there. A bag filled of fluid there. Okay. These are very bulky vocal cords, aren't they? What is this? What's the diagnosis, do you think? Khadija, what's the diagnosis? Khadija? Danusha, what's the diagnosis?
Are they polyps? Or...
Well, you wouldn't call for, you're sort of hedging near the right answer. It's the thing, the whole of the cord is pretty much swollen, isn't it?
So just edematous, or
it's very edematous. It's called Reinke's edema, edematous edema. And basically, there's a the cord has several layers, okay? And in one of the between 2 of the layers there's a space called Reinke's space. It's usually no space, but fluid can accumulate in it and produce this swelling called Reinke's edema. It's usually in people who smoke, who talk, and voice quality is called a gin and midnight. Do you ever drink gin?
Yeah.
Smoke?
No.
Gamble? You know the sort of you see on television or on films. You know they get this really gruffy, low-pitched voice. That's the voice quality you get, and it's low-pitched because a vibrating cord that's this fat, its fundamental frequency is going to be a lot lower than if it was a smooth, nice vocal cord, not swollen. So the pitch is way down here somewhere, right?
Where is the swelling in between?
Well, there are several layers of the vocal cord, and one between 2 layers is a thing called Reinke's space. It's a potential space.
Okay.
And it's swelling in Reinke's space. That's why it's called Reinke's edema.
How do you spell Reinke?
R-E-I-N-K-E. R-E-I-N-K-E.
Thank you.
Okay. So the presentation here is usually a low-pitched dysphonia. The only thing you need to worry about is what? There may be a cancer lurking under here. So these patients need to be seen by an ENT surgeon, even if you see them in the community. Okay? Just to make sure there's nothing else going on. But generally speaking, they settle with speech therapy. Occasionally you might need to remove this bulky edema under anaesthetic. Okay, I think that's probably enough. Any other questions on what I've presented, or any other more generic questions on ENT? I'm happy to take. That's open to everybody.
Just with the last slide, you said that we should always refer those patients to ENT. Would they biopsy that to then look for a tumour, or how would they?
They will take a history. If it's a 25-year-old lady, non-smoking, they probably just say, let's go with speech therapy. And frequently these patients have been having symptoms for 12, 18, 24 months, so it's very unlikely to be a cancer. It's not going to be sticking around like this. So it's taking a global view. But as I've said, if this is a history going back 2-3 years, you could have a short, sharp course of speech therapy. They all need speech therapy, because unless they learn corrective methods, it's just going to come back even if you have surgery at a later date. But I think the general principle ought to be that unless it's something very obvious from the community, you need to get it sent. If you see vocal cord nodules, I understand. That's not a problem. Or just a general redness of both vocal cords, and they're fully mobile, that might be just vocal misuse, in which case speech therapy direct referral will be fine. The speech therapist will send the patient or suggest you send it to ENT if things aren't improving. So there's always a get-out clause, yeah? Okay, any other questions?
It may be too late.
Yeah.
But for other sessions, is there any chance of getting more teaching on nasendoscopic and laryngeal views of stuff we might see on the endoscopes?
Yeah, well, can we make a note of that, Sean?
Yeah, that would be really useful.
Yeah. We can do something.
It's like unless you see it, you're in clinic, you just won't see it.
Yeah, I know. Well, it's you just got to do a lot of scopes. Yeah, but for your purposes, you got to feel for things. That's what you need to be able to get. Any other questions?
The stop ban questionnaires, are they being used nationally now?
No, because unfortunately, quite a lot of departments for snoring and obstructive sleep apnea are run by respiratory physicians who don't have a clue what they're doing. They tend to use the Epworth Sleepiness Score, but we are promoting, as ENT surgeons, the Stop Bang Questionnaire, which, as I say, is much more specific for obstructive sleep apnea. So an increasing number of departments are using it, yeah.
Is it used nationally by ENT now?
Well, I don't think nationally it's being used, but an increasing number. We're trying to get a subsection of ENT UK for obstructive sleep apnea, but that hasn't happened yet.
Yeah.
Anybody to do anything, Daniel, it's bloody difficult.
So in practice, are you giving these questionnaires out in the outpatient department or?
No, you're in general practice, aren't you?
Yeah.
Okay, so if somebody comes into you with snoring, you take a general history, and then you ask a specific stop bang questionnaire. If you get a score of 4/5, they probably need a proper assessment.
Mm-hmm.
Yeah.
Yeah.
If they get 6 or 7 or 8, they definitely need it. 4 or 5, you might start a little bit of lifestyle stuff and then ask them to come back and redo it. Yeah.
Yeah.
But if it's 5, 6, 6, 7, 7, 8, I think you'd probably be wise to send them through.
Okay.
Any other questions? Where are you based, Saida?
So I'm based in Hertfordshire.
Oh, right, okay.
So I've been doing ENT clinics in the L&D.
Oh, right, with Prasad?
Mr. Chawla.
Oh, right, okay, Mr. Chawla. Yeah, he knows me, yeah. Okay, that's good. Any other questions? What about the Sharjah crew? They've all gone to sleep. I think if there's no other questions, study hard. I hope you've learned something. Medicine is very, very interesting, exciting stuff, and every little bit of knowledge helps. So for family medicine students, I hope you found this of some interest. And for the ENT UK students, I hope you found it a lot of interest. All right, provide some feedback. And if there are other topics that you want sort of discussed ENT-wise, Daniel has already mentioned a couple of things. If any other of you, drop an email or let us know. Yeah?
Yep. Thank you.
Okay.
Thank you.
Bye-bye.